Hello, my name is Zahra Koussan. I'm the Associate Director of Community Partnerships at the American Cancer Society.
And I'm Dr. Muresan, one of the residents from WMed here at Grace Health.
We're here to talk about cancer prevention, risk factors, and ways to stay healthy. Dr. Muresan, do you want to talk about Grace Health's mission?
Yeah,
Before we
so
start off?
here at Grace Health, we have a goal to provide patient-centered healthcare, and really our goal is to have our patients here in the community achieving their full potential for both their health and well-being, not just here but at home and at work. And we want to build a trust and partnership that patients can collaborate with us and feel open to be able to ask us different questions, and make it feel like we are available to them. And that's really what this is about as well. We want to make patients feel like we are available here and you can ask us any question you want.
Definitely. The American Cancer Society's mission is to improve the lives of folks with cancer and their families through advocacy, research, patient support, and ensure everyone has an equal opportunity to prevent, detect, treat, and survive cancer. With that being said, we're going to be talking about different topics of cancer, and risk factors and prevention, as mentioned. And I guess we can go ahead and get started talking about colorectal cancer. Colorectal cancer is actually the third most common type of cancer in men and women in the United States. 1 in 5 cases will be with folks finding out they have cancer under the age of 55, colorectal cancer. 1 in 3 will be diagnosed with colorectal cancer due to family history at an earlier age. Unfortunately, Black individuals do have the second highest risk of being diagnosed with colorectal cancer and being seeking help later on after this cancer had spread throughout the body. Is there anything else, Dr. Muresan, you wanted to add about colorectal cancer before we move on to talking about risk factors?
Yeah, I think that being said, when we talk about risk, I think one of the most important things to bring up as we kind of reach this next section of risk factors is what are risk factors? And a risk factor for us physicians kind of falls in two broad categories, and that's what we call modifiable and non-modifiable. So you mentioned one of them being non-modifiable, being race, age, and these are things that we tend to say you exist with these qualities. And then there are modifiable risk factors, which might include smoking, diet, or lifestyle. And so yeah, and that kind of is a good preamble to a discussion on how we use risks and what we talk about.
That's a good point. To your point, cancer risk factors are usually something that increases your chance of, being diagnosed with a certain type of cancer. As you mentioned, age, race, family history also play a role in risk factors. And some colorectal risk factors include personal history of colorectal cancer, or having polyps, or people with inflammatory bowel disease, or even people with inherited gene changes, or folks with type 2 diabetes. So I guess a question for you, Dr. Muresan, is how do risk factors become recommendations?
So yeah, that's a great question. And so risk factors have a primary challenge for us where we ask the question, okay, you have this risk. When do we actually make a recommendation for things? And this is where we turn to a lot of our guidelines who have curated a lot of research in these areas. So for colorectal cancer, as an example, we recommend screening between the ages of 45 to 75. And the reason we don't recommend earlier than 45, it comes down to those risk factors. So yes, you may have a family history, you may have different things that make you higher risk, but if you screen too early, you end up getting a procedure that is unnecessary and we probably won't find anything. So that's where these recommendations come from and how we use risk factors to tailor these recommendations. So then the next kind of obvious question a lot of patients tend to ask is, well, I don't have any risk factors, why should I screen? And it comes back to what you were saying earlier, is there are things that we do that give us risk factors, and then there are things that we don't do that give us risk factors. And we don't know all those risk factors. The only thing we do know is we can check to see if there is something happening.
That's a good point. And I guess that leads to my second question, are, what types of screenings are out there for colorectal cancer?
Yeah, so when you come to Grace Health, we will typically recommend what's known as a FIT test, and a FIT test is done every year. And another test that you'll hear as well here at Grace Health is a colonoscopy, and that one is usually done every 10 years. And there are a few other tests in between that we do offer. There's another similar test to the FIT test that's done every 3 years. And there's one more test that we really don't offer here at Grace Health just because of the availability, which is something like a CT scan, and that would be done every 5 years.
Okay. All right. That's good to know. Before we move on to our second type of cancer focus, is there anything else you wanted to add on or address in regards to colorectal cancer?
So one of the other things that often comes up in an office visit is, well, I'm worried about the results. I'm worried what happens if my stool test, this FIT test, is positive. And oftentimes it has to be a very open discussion where we have to address that need. So if someone is worried about the result, we have to kind of talk about, well, what's the next steps? So if you do a FIT test, which is an examination of your stool, you'll need to send that in to us and we'll evaluate it in the lab. If it's a positive FIT test, meaning that there's concern that there's either bleeding or something else detected, we would then recommend you to have a colonoscopy. And the colonoscopy is really just a camera that is inserted into the rectum, and we look for polyps and we look to see what we can find, and we'll take out a sample of that and send it to the lab to evaluate. And that's really your first steps, is kind of going up to the colonoscopy. And oftentimes you'll wonder, well, why not just do a colonoscopy then? Why go through all the hassle of doing a FIT test or these other stool tests? And the most important answer to think here is a colonoscopy is a procedure. You need anesthesia to complete this procedure. You need a camera to be inserted for this procedure. Whereas if I give you a FIT test, you really can just go home, you have a container, you collect a piece of stool, and then you send it to us to evaluate. There's no risk to you. You kind of everyone goes to the bathroom pretty regularly, so it doesn't add any risk. The only risk it adds to you is the time it takes and the possibility of finding a positive test. Now, the other kind of caveat to positive tests, and we'll hear about it a lot, especially when you start looking on the internet, is false positives. And false positives are a possibility, right? And that's why we do the colonoscopy, to help minimize this false positive risk.
Based on your experience, would you say colonoscopies are more popular than Fitbit?
So the FIT test and are more popular is maybe not the most common way we'd refer to it. So colonoscopies were the initial way that we used to test. And the colonoscopy was what we considered the gold standard for a very long time. And new research has come out which shows that colonoscopy is equivalent to the FIT test, and there is no real benefit that you get. The kind of interesting piece about colonoscopy is a colonoscopy itself gives you harm, whereas the FIT tests do not include the same amount of harm that's associated with the procedure. So just to be clear, the most common risks associated with a colonoscopy would be the risk of the anesthesia. So any adverse event associated with that, it would be risk of actually injuring the intestines when you put the camera in, and then a bleeding risk, all of which don't exist with the FIT test, which is oftentimes why we recommend the FIT test.
That's a great point. People do tend to get confused between, the both of them, and I could see why. But thank you for addressing that. We can move on to start talking about breast cancer. Women and men are both at risk of developing breast cancer. 2024 estimates of new breast cancer cases are at 310,720 cases in the U.S. and unfortunately 43,700 deaths. So I know they may seem like large numbers, but we've also come a long way in research, breast cancer research, and promoting breast cancer screenings. Can you talk to us more about that? In today's time.
Yeah, so breast cancer and the research in this category is actually quite interesting in the way that it's developed. So a lot of people, if you kind of think back a number of years ago, would have seen commercials about self-testing. You would have gone to the doctor's office. We would have recommended self-testing, breast exams, and then you would have done a breast exam at the doctor's office. But that no longer is part of the recommendation. We do not routinely recommend breast exams. We do not routinely do breast exams in the office. What we do, however, recommend is that you do get a mammogram between the ages of 50 to 74 every other year. So that's every 2 years. And there is other recommendations that you'll see here even at Grace Health where you can get a mammogram between the ages of 40 to 49. And there are some caveats associated with how we would select people to get a mammogram between the ages of 40 to 49, and it is based on risks. And there are challenges associated with getting a mammogram earlier as well.
Yeah, and also I wanted to address barriers to getting screened, such as fear, or what if I do test positive? Let's address that. Let's talk about it. I know this is a common type of fear in all types of cancers, not just breast cancer. But how are we able to address that as professionals, as providers? How do we move forward and talk to patients and let them know that fear shouldn't be a barrier and that we really should get screened?
Yeah, so that's a very common question, and it's a great question. And with fear, the challenge is we need to understand what you're worried about. Is it the worry is that I might have a positive test, or is the worry that I might not want to do all the further steps required, right? Because at the end of the day, having a positive breast cancer screening means you're going to at some point be recommended a biopsy, meaning someone will place a needle in and get a sample out. And then after that, it might be more imaging, it might be more procedures, and then at the kind of end of the spectrum, you would hear of things like mastectomies and different surgical interventions. So the question often becomes is, well, how far am I willing to go? And if your belief is you would like everything done and you would like as much prevention as possible, this is kind of these steps that you need to go through. And that's why we always want to have an open discussion to say, well, this is what we're trying to prevent. These are kind of the steps that we go through to do that. The kind of, if we remember back to the caveat I talked about between the 40 to 49-year-old, why we don't routinely recommend screening is for this very reason. When we do screenings in this age group, it is very likely to get a positive finding that doesn't really have much clinical meaning that it'll not change much over time. And that's because breast tissue can be very dense in the early kind of phases. But we know that as people get closer to 50 years old, nodules and things we'll see on the mammogram are more likely to need a biopsy or some other intervention.
Follow up, yeah, exactly. Which leads, I guess, to my other topic, lumps, feeling lumps. That shouldn't be a way to detect if I have breast cancer or if I should go get screened, because sometimes even you might have cancer, breast cancer, and might not even feel the lump. So that's why we highly recommend getting screened and talking to your provider and seeing what the best method for you is. Do we want to talk about screening intervals real quick?
Yeah. Actually, I'd like to mention something about lumps as well. So if you do feel a lump on your breast exam at home, if you just happen to feel one, please tell your provider as well, because we would typically recommend mammograms or some sort of screening or imaging depending on what we would see, because there's a whole range, as you were saying, of it's just a lump to it's something else, right? So it's important to keep that in mind. But in terms of screening intervals, we recommend every other year, biennial or every 2 years. And the reason for that recommendation is it helps to prevent what we call overdiagnosis, meaning that we will see things and then intervene on things that actually shouldn't be intervened on.
Exactly. Thank you. I think we can talk about risk factors that you cannot change with breast cancer, which also include Sex, age, personal or family history. Other factors include drinking alcohol or being physically inactive. Ways to prevent those types of risks, or to reduce your risk of getting breast cancer, is to avoid drinking alcohol and to get to and stay at a healthy weight, to eat healthy, have a healthy diet, and exercise. Any other tips and tricks you recommend for prevention?
Yeah, so another important kind of category to always remember is knowing your family history.
Yeah.
Because if you know your family history and you come to the doctor's office and you, for example, would like a medication, one of the important things that we often do is there a risk of this medication worsening something you already have? So being aware of your family history goes a very long way.
Yes.
And then if you are concerned about things, we very strongly recommend that you ask the question, well, what can I do? And if you're struggling to think of different ideas, here at Grace Health, we have a lot of resource teams and specialists who are able to help you kind of go along that right path and help check in on you and make sure that you are kind of meeting the goals that you actually want.
Which makes sense, and definitely I agree with you 100%. We can talk about cervical cancer now, if you're good with moving on. Cervical cancer does start in the cells lining the cervix in the lower part of your uterus, which is also known as the womb. The number of cervical cancer cases has been reduced dramatically by more than half in the past decades, which is amazing to see that we're advancing in our research and whatnot. I guess we can talk about some risk factors regarding cervical cancer, which may include infection by HPV, smoking, having a weakened immune system, history of chlamydia infection, using oral contraceptions for a long time, having 3 or more full-time pregnancies, also being under the age of 20 and having full-term pregnancy as well. I guess my question for cervical cancer is, how often do we test for it?
Yeah. So cervical cancer, as you were saying, it has a lot of risk factors. And another big risk factor that needs to be mentioned is sexual history. So a history of multiple sexual partners increases your risk. And so when we talk about screening intervals, there's really 2 major recommendations with it. And so the first one is between the ages of 21 to 29, we recommend a pap smear every 3 years. After the age of 29, so from 30 to 65, you have a few more options now. You have the option of doing a pap smear alone, being every 3 years, or you can do a HPV check with your pap smear, and that gives you about every 5-year interval recommendation. And for those of you who are not aware what a pap smear is a procedure that we do in the office where we visualize the cervix and we use a small brush to scrape the cells off the cervix, and we send that to a lab to look at underneath the microscope. And with HPV testing, what we're really looking for is the virus HPV itself present. So the virus itself can cause or lead to cervical cancer.
Great points. And ways to prevent cervical cancer is to get your HPV vaccination, regular screenings, quitting tobacco, things like that, which I feel we kind of covered when we were addressing risk factors. Is there anything else you wanted to add in regards to cervical cancer?
Yeah, so the screening intervals are not set in stone either. So we typically recommend against anyone screening below the age of 21. And there's a caveat to screening above the age of 75 as well. And so really our recommendation below 21 follows the following rule, which is that children and young adults tend to overcome either the HPV vaccine or HPV, like the virus itself, or any sort of change in the cell structure. And so really the strongest changes that we start to see are when you're getting closer to 30 years old. Including the virus itself tends to be more set when you get closer to 30. And that's why we don't recommend co-testing below the age of 30. Now, if you do test positive for HPV or on the pap smear, your interval for follow-up will change. So remember how we talked about every 3 or 5 years, depending on what you selected? It could be every year for a little portion of time. And we could also recommend something known as a colposcopy, which is also another office procedure. And that procedure is where we take a sample of the cervix and examine it under the microscope.
That's a good point. I think we have a question in the chat. Does a PAP rule out other female reproductive cancers like uterine? I'm sorry, like the
Uterine cancer?
Yep, uterine cancer.
No, it does not. So the pap smear itself is looking specifically at cervical cancer. So when we talk about the female reproductive tract and we're worried about other cancers, there are a few sort of signs we look for in the office that we don't necessarily routinely screen for, but they present differently. So abnormal uterine bleeding is one of the most common ones. And if you told your provider, hey, I'm bleeding a little more than I expect, they might recommend a procedure, which would be getting a sample from your uterus lining to see what's going on there. Other options include imaging if there's a lot of pain or discomfort, all the way ranging up to something like a laparoscope, which is sending a camera in to look. So there's a couple different options available, but no, it would not screen for uterine cancer.
All right. Okay. I think we covered most of what we had for cervical cancer. We do have another question in the chat. Is screening required more frequently for all HPVs or just certain types of HPV?
So typically when we do the HPV screen, we are doing it for the high risk HPV strains. And those ones are most strongly associated with cervical cancer. So if those are positive, it will change your interval of testing, and it usually ends up making a recommendation to get a colposcopy at some point. So if it was just the HPV swab alone, we would really want cytology as well at some point, meaning the pap smear, because you are able to choose one or the other option.
Let's see. Those are great questions, and if anybody else live has any questions, please pop them in the chat and we'll be more than happy to answer them. In the meantime, we are going to move on to start talking about lung cancer. Lung cancer is the second most common cancer and leading cancer death in the United States for both men and women. Lung cancer is often caused by exposure to tobacco, smoking, and other airborne chemicals. I know there's a misconception about lung cancer. Hey, if I don't smoke, I'm not going to get lung cancer. But as providers, as professionals, we know that's not the case. You know, some people are exposed to certain chemicals and they may not know it, or have family history. Can you talk more about why it is a misconception?
Yeah, so the interesting thing about the lung cancer screening is we often will think of it in the context of smoking, and that is because the screening is in context to smoking. Now, it doesn't include the nuance to what lung cancer is, as we're talking about. And one of the biggest kind of groups that gets left out in this smoking specific protocol is occupational exposure. So if we kind of think back a number of years ago, asbestos was a very common insulator that we used in the walls and even in the drywall. They would put horsehair and asbestos as a common binder, and we don't see that anymore now, or it's phased out. It's still used in some industries, asbestos, for its specific properties, and there are other occupational concerns as well, so beryllium and arsenic. And people do get exposed to these at work, and it's important to tell your provider, hey, I work at this, and they do have a workplace hazardous information sheet that they've told me about. And usually with your employer, they will tell you this is the chemicals you are exposed to. So if you are concerned that it might change your screening intervals, you should let us know. Because if you don't tell us that you do have this workplace exposure, I won't order a low-dose CT or screen you for lung cancer if you're not smoking.
So I guess that leads to one of my questions. Let's say you are exposed to certain chemicals at work. What can you do to avoid those chemicals? Is there certain things you need to wear or ways to protect your body?
So I would recommend whatever PPE is designated by your employer, you should wear. If you are dealing with fumes and paint dust or whatever other exposures that are aerosolized, if you're supposed to wear an N95, a suit with a respirator or anything, you should be wearing it. You expose yourself to an unneeded risk if you don't do any of those things.
Great point. Some risk factors to lung cancer include tobacco use, secondhand smoking, as well as we mentioned, exposure to harmful chemicals or personal or family history. So always speak with your provider and let them know, as you mentioned, just where you work, your setting, even in your home, if you're exposed to, if you live in an apartment, if somebody smokes or things like that, if you smell smoke, how you should react to that. I know we did have a couple of questions on the chat. Do you screen for people around secondhand cigarette smoke?
Not routinely. It is not a routine recommendation. It is very much a possibility to have screening for it. And oftentimes, the way we refer to it is clinically, we would see other signs. So if someone was exposed to secondhand smoke, they often do present with some sort of shortness of breath or difficulty breathing. And it might prompt a workup that's a bit different, which is to examine how your lung is functioning, but not necessarily in the cancer screening route. Mm-hmm. And then I think there was another question there.
What is the connection between radon exposure and lung cancer?
So I don't know there's no specific guideline on radon exposure. Typically, we make a lot of recommendations about your housing. So if you live in the basement, you should be having some sort of radon check, which depending on your region, they do have those regularly done. But in terms of the risk to lung cancer, I can't speak specifically on the data there. I'd have to check that.
No, great points. And some prevention methods or ways to reduce your risk of getting lung cancer includes avoiding all tobacco products, meaning smoking, staying away from secondhand smoking, keeping cars and homes smoke-free, and avoiding cancer-causing chemicals in your home or in your workplace, and eating healthy and exercising. I do have a question in regards to timing of recommendations. So what are your thoughts on that?
Yeah, so lung cancer follows what we call a 50-80-20-15 rule. And so what that means is if you're between the ages of 50 and 80, we recommend that you get lung cancer screening if you have smoked for at least 20 pack, so having a 20 pack year. And so a pack year is someone who has smoked a single pack of cigarettes every day for 20 years. So if you're between 50 to 80 and smoked 20 pack year, we recommend a low dose CT scan every year. Now, if you've quit for over 15 years, you no longer need to have screening for lung cancer.
Those are good points. I guess we can move on to talk about prostate cancer if we're all set with lung cancer.
I think we could talk maybe, before we get to prostate, for lung cancers, I think one of the most important things that we do need to recommend is smoking cessation. So that is, if we include guideline recommendations, we always think of the lung cancer recommendation, but there's actually another guideline recommendation, which is tobacco use guidelines. And those are very strong recommendations, which is every visit, if you smoke, we should be recommending you ways that you can quit. And if you are amenable to that idea, there are various options that can help you quit. And this kind of plays into that lung cancer screening where if you've been tobacco free for 15 years, you don't need these screenings anymore. And your risk of getting lung cancer gets very close to that of the general population. So if we kind of work with you and you would like to work with us about smoking cessation, there are a few options available that range from just patches to gums and lozenges. And then there's other medications that we can provide as well. The Michigan State also, here at Grace Health, we can help you fill out the state form, which is for the tobacco quitting resources, and we can get them right to your doorstep essentially with everything you need. And it's just talk to us, we can get it to you, and it's going to be no cost to you.
Yeah, definitely. Also check out the American Cancer Society website. We have tons of resources. We have ways to connect you with folks that really are able to help you, and you can learn from them. and ways to, stop smoking or ways to reduce that. There's the Michigan Quit Line. There's tons of resources, as you mentioned.
And actually
Yeah.
sticking to the schedule. So
Yeah.
lung cancer screening is one of those oddities in the US where it has one of the lower compliance rates overall, meaning that a larger amount of people are not getting that yearly screen. And it's, as you said, it's one of the higher risk cancers that we do see in a lot of populations, and we catch them somewhat too late because of that. So stick to the schedule. If you do smoke and you're not at that stage where you want to quit, or you say, you know what, I just want to smoke, it's my thing, you can take a step in the right direction. The caveat to all of it that you should be talking about is if you do find something on this cancer screen, what do you do with it? And you have to have a very open discussion, meaning if you're 50 years old, you might say, well, I really want to keep living. I want to go through the 9 yards. I want to do everything possible. I'll do radiation. I might do a biopsy. I might do everything. But if you're not willing to kind of go through the next steps, I think you have to tell your provider and see what kind of testing schedule might suit you better.
That makes sense. I see we have a question on the chat. How big or small of a factor is family history and likelihood of getting cancer? And does it differ depending on the type of cancer? Also, is exploring family history the same concept as genetic predisposition?
Yeah, so that's a great question. So we see very strong association with some cancers. So the ones that we're talking about today, that colorectal, breast, cervical, prostate cancer, those have a very strong genetic component that does exist. So familial history goes a very long way. Now, if you remember back to our earlier discussion, there exists two types of risks. We have modifiable and non-modifiable. So we're in the lung kind of cancer section here, and there are, once again, two kind of cancers that you can say exist here, which is exposures. So whether you're exposed at work or whatever habit you might have that includes smoking, or a genetic component. And really, when we're talking about screening in lung cancer, we're trying to prevent that modifiable risk factor, that smoking risk factor, and that one carries the highest risk. When you do have a family history of something, disclosing it to your physician helps the physician to be aware of that health history, and we might order a single test or a single exam at some point to screen you, but that would be outside of the normal recommendations, if that makes sense.
Definitely.
And then there was, is exploring family history the same concept as genetic? Yes. So it would be a similar concept in that when we talk family history, most people will not be aware of the specific genetic of the cancer. They'll just be like, oh, I had colon cancer, or oh, my uncle had thyroid cancer. You don't really know which subclass or which genetic makeup it is. So when we're discussing that, we typically will make the assumption that, oh, there is some familial relationship, there is some genetic component to it.
Thank you. Those are great questions. Keep them coming, and if we're able to, even in the end, answer more questions, that's totally fine. We can talk about prostate cancer. Prostate cancer is the most common type of cancer in men other than skin cancer, and is the second leading cause of death after lung cancer in the United States. Dr. Muresan, can you talk to us more about prostate cancer?
So the prostate cancer, the digital rectal exam, the prostate exam, as a lot of men are afraid of getting, is no longer actually routinely recommended. We don't recommend doing digital rectal exams. We don't recommend routinely to do prostate-specific antigen, which is the blood test. It's just no longer part of the recommendation. And the reason for that is over kind of the years, there's been a change in how we've essentially seen the research go. So when we talk risks and when we talk cancers and we talk detection, an important concept that we haven't really talked about yet is the concept of misdiagnosing and overdiagnosing. So for everyone, misdiagnosing is when we look, so if we take a nodule, a bump that we see, we would say, oh, that's just a bump, and we might say it's nothing. And if it turns out to be cancer, that means we made a mistake at some point, and that was a misdiagnosis. When we talk about overdiagnosis, we say, oh, that bump is cancer, so we got the correct diagnosis, and then we start doing radiation, we start cutting things out, we start doing something. When it turns out that if you were to have lived your full life, that cancer would have stayed a little spot, wouldn't have grown, wouldn't have changed. And so that's really the discussion with prostate exams is we see a lot of changes with the prostate. They do get bigger as we get older. They do get bumps, and not all those bumps actually mean you're going to die from it. You might have it present when you die, but it may not actually be the thing that kills you.
So, okay, I guess I can lead on to some risk factors in regards to prostate cancer, which include age, race, ethnicity, family history, inheriting gene changes. Some ways to prevent prostate cancer. Unfortunately, there is no specific way to prevent it. However, there's ways to reduce it by exercising, eating healthy, maintaining a healthy weight, having a healthy diet, including vegetables and including low-fatty foods. Is there anything else you wanted to address in regards to prevention or risk factors for prostate?
Yeah, so when we talk about something that we don't routinely screen for, the question always becomes, well, how will I know I have it,
Yes.
right? If we don't check for it, how do I know? Should I just get it screened anyway, just because? And the answer is a little more nuanced as we would say it is. And the reason for that is because we really want to go off of your symptoms. And the unfortunate part is your symptoms may be coming on too late, meaning that we'll detect it at too late of a spot. And the flip side to that is if we just start testing you, we get into this overdiagnosis phenomena. And when we talk prostate cancer specifically, if you want to have PSA, which is the antigen test, you should talk to your provider about if it's positive. Are you willing to go get that biopsy? Are you willing to go through a full procedure? And you should be aware that the risk of having the procedures are not trivial, right? So anyone who gets screened with it and gets a positive PSA has between a 20 to 50% chance of having that positive being normal or not leading to a death, right? So that would be that overdiagnosis. So 20 to 50% will be overdiagnosed. And you have to have that discussion with your provider to find out if this is actually something you would like to know or like to have worked up.
Question, how likely these days are you to be overdiagnosed?
It really depends on the test you're doing.
Yeah.
So when we're dealing with any of these screenings, it is possible to be overdiagnosed. And a lot of the way that we conduct the research is by longevity or life expectancy. So if we take colon cancer as an example, the way that we report the data for its benefit is by how many years of life expectancy an individual will gain from doing this procedure. And since it's done on a population level, so if someone has colon cancer screening, we'll say if 10,000 people are screened for colon cancer, we will improve that group's life expectancy by about 290 years, meaning that in that group, you may have people who gain 50 years, some who gain 0, some who gain 1 or 2. But overall, we know that there's a net benefit of 290 years of life in that group. When we talk about prostate cancers, we're not really getting that same life expectancy benefit. We get this phenomena of overdiagnosis where people would have died with something else but have prostate cancer.
I see. Okay. That makes sense. Is there anything else you wanted to add before we move on to skin cancer?
No, I think we covered a pretty good portion there.
I agree. All right, so skin cancer is the most common type of cancer in the United States. Some risk factors include exposure to UV light rays, having light-colored skin, age, gender, having a weakened immune system, as well as moles or personal history or family history, radiation exposure to certain chemicals as well. I know some popular methods to prevent skin cancer include using sunscreen, SPF of at least 30, or wearing long clothes, covering your skin, sitting under the shade, avoiding the sun, basically. What are some misconceptions about prevention in skin cancer?
So I think the most common misconception that I hear frequently is, oh, it was a cloudy day, or it's winter, or I'm under a tree, or something equivalent to that. And they'll say, I don't need the sunscreen, or I like to tan is another common one. And I just want to dispel all of those kind of rumors. You can tan with sunscreen on. It simply blocks the UV radiation. What it helps to prevent is the burning phenomena, but you will tan. You'll tan without a burn. You do have to reapply the sunscreen quite frequently, but that's just kind of because it washes off, especially if you're sweating or going in water. The other one is during the winter.
Yes.
Just because there's cloud covering or there's winter and no direct sunlight on you doesn't mean that UV radiation is not hitting you. It's something that we can't see. So it goes through the clouds, goes through some shade, and it is very present in the winter. It reflects off of different surfaces as well. So we recommend, if you're going outside, especially with young children, 1 month and older, to have some protection for their skin. And really the strongest recommendation is between that infant stage all the way up to the end of adolescence. That's when you really get the most benefit by applying sunscreen. Most people have gotten the damage to their skin done all the way after adolescent.
Yeah. So, out of curiosity, why aren't there any type of specific skin exam
Yeah, so
promoted?
much like with the other recommendations, we see that over the years we kind of change our philosophy on how we do things. We don't do prostate exams, we don't recommend breast exams, and we don't recommend routine skin exams either. That doesn't mean, though, that if you have a mole that we'll ignore it, right? So if you do have a mole, you can do your due diligence and kind of look for it and see how it grows, but we wouldn't routinely say, hey, come to the office and do a skin check. And the reason for that is it comes to overdiagnosis and misdiagnosis. When you have a small skin lesion that we'll see, the easiest thing to do is actually just remove it. It's a very quick procedure, and after you've removed it, we'll send it to get a biopsy, and in the biopsy, we'll often find that it's benign. Now, if you do have a concerning mole that you've been watching and you have a family history of skin cancers, you should be evaluating those moles specifically.
Agreed. We do have a question in the chat. Does the use of sunscreen impact vitamin D levels in individuals?
And okay, so in terms of the vitamin D levels, no, it does not. So sunscreen specifically is blocking UV radiation, and that's what its design purpose is for. And so UV radiation specifically hits our DNA of the cells, and it causes them to change in different ways. When we're talking about vitamin D levels, we're really talking about our body's response to the sunlight itself, which does not, in our instance here, refer to the UV radiation. We're really just trying to block UV radiation. Now, if we're talking other things that people often do, which do harm the amount of vitamin D you get, and that is wearing long sleeve clothes, covers, hats, and hoodies, that blocks out the sunlight, right? So it doesn't block out UV rays, but it blocks sunlight. And so those instances, we often recommend that if you are worried about vitamin D depletion, that you should be going out in a short t-shirt or getting some sort of neck, face, arm, leg exposure to the sun. But if you put that sunscreen on, you'll prevent the UV from hitting it.
So sunscreen is a big deal. Great. We do have another question. If you have a family member who died of cancer, but no one really talked about what kind, would you recommend screening for all cancers early?
And that's a very good question. Yeah. And oftentimes when we don't know the cancer, we typically don't recommend, so it'll be not a recommendation to get a full body scan. We would target the specific organs that would be of concern. So if you are a smoker, as an example, we'd say, okay, you should get your lungs checked. And if we don't know what kind of cancer your family member had, we would just ask you to be vigilant and keep an eye out for anything that would change in your own body. We would recommend the regular screenings for your blood work as well, and that can go a long way to detecting some of these things.
That's good to know. You know, out of curiosity, have you ever had patients who are totally unaware of their cancer history, family history, whether, you know, if they were adopted, or maybe they're just unaware. How do you, I know you said you don't recommend full body screenings, but how do you, as a provider, deal with a situation like that?
Yeah, so that's a very good question. And oftentimes, the unfortunate answer is you'll find out some of these things too late. And part of the reason what makes prostate cancer and lung cancer so deadly is when they do manifest and in a way that we see. So when you start coughing blood, when you start having stools that are mixed with blood and there's a lot of pain, you're often at a very late stage. And there's no real way to screen someone without overdiagnosing or misdiagnosing in the early phase. So the other kind of thing about full body scans is if we do a full body scan and we find something, are we misdiagnosing it or overdiagnosing? So there exists also within the literature, when you start reading how we make these recommendations, if we start treating people and testing people at an earlier phase than is recommended, we actually end up doing more harm to the patient and the people around us than we actually do by benefiting them. So you get radiation exposure for some things, you'll get unnecessary procedures, and your risks are there.
Which kind of leads to our next topic of guidelines. So based on what you're telling me, it's highly recommended, even at ACS here, we recommend you follow screening guidelines. And some health centers may have different guidelines. Do you want to talk more about why that might be?
Yeah, so there are different guideline recommendations, and this is true for almost all of these guidelines here. So in family practice and at Grace Health, we tend to follow the USPTF guidelines, and those very closely align with our screening intervals as well. But you'll also read with the American Cancer Society that some of their numbers and intervals are different. And it's not to say that ours are better and theirs are not. It's simply a different approach to the information available. So when we look at the information, we might say, well, we believe that we should do this at this age bracket because we see a good benefit. And the other society might say, well, maybe at this age we see the best benefit. Where we do always agree on is actually the high risk population. So our data and recommendations are always broken up into A, B, C, D, and I recommendations. So typically here at Grace Health, we give you the A and B recommendations, and those are always given. And with those come some nuances. So A means there's very strong evidence to support that this will have a meaningful change. A B recommendation is there's a strong evidence to show that there'll be a moderate change. And a C evidence is there is evidence to show that there will be a small change, right? And so that kind of gives you a little line to work with where you're like, well, the small change, I feel we're overdiagnosing or misdiagnosing, so we want to move that up so that we're closer to that B and A recommendation. And so at the end of the day, whether you're using a different society's numbers or our numbers, you will be getting optimal care always. We will always look after you.
Definitely. Always consider your lifestyle and your family history. That also affects when you can get screened out early. Always talk to your provider and see what next steps and what works best for you. So we talked all about cancer prevention, risk factors, guidelines, tips and tricks.
Yep.
Let's talk about how to live healthy. You know, the most common types of ways to stay healthy is staying away from tobacco, secondhand smoking, eating healthy, being active, getting HPV vaccination, protecting your skin, and all the things we really talked through today. But how are ways we can actually implement these in our daily lives?
Yes, and that's actually one of the most common questions I get asked is, well, you've given all these recommendations. How do I implement them? Who has 1 hour every day, 5 times a week to do moderate to vigorous exercise? Who wants to change their complete diet every single day? And the way that we find the most success is people who are able to do things in their normal day-to-day activity, right? So diet is one of the easiest ones for us to think of. And so one of the recommendations that I have found most helpful to a lot of people is, are there things that you can change with your purchasing in the grocery store that can have a meaningful impact? And one of the easiest ways that I often recommend that is you just ask a simple checklist in your mind about the item you're buying. How processed is it? This is the easiest question every one of us can do at Myers or Walmart or whichever grocery store we want to go to. How processed is it? So the question is easily answered. So you look at a bag of chips the bag of chips had to be processed in multiple ways, right? Someone had to pick the potato, someone had to cut the potato, someone had to fry the potato or bake it, salt it, put it in a bag and give it to you. The least processed item would be the potato, right? Someone had to pick it and bag it. And this is how you can kind of apply it to your life when you grocery shop. Oh, I want to get a salad that's been already processed versus I want to just get the ingredients myself and process it myself, right? It kind of takes the middleman out of a lot of your shopping. And this is an excellent way to pick anything, right? So a hot dog is more processed than a piece of beef or a piece of pork, right? And so you can go in this way and it'll help you simplify some of the decisions and make it so it can work in your life. And that's where we find success, is when people can actually do them.
Definitely. Another popular or a great method is meal prepping.
Meal prepping, yeah.
Some folks meal prep a day or the night ahead or maybe even a week ahead. There's a lot of videos out there, influencers that you can really learn from and see how you can get tips and tricks in improving your health, your nutrition, your diet, things like that. Of course, there's many resources out there that you can utilize, whether it's at Grace Health's website or even at the American Cancer Society or even out. There's tons of resources you can learn from to really see how you can benefit your lifestyle and make changes in your lifestyle. Other things you can do, obviously, other than speaking to your primary care doctor and seeing when you can get screened, is also encouraging your loved ones to get screened as well. Protect yourself from the sun, avoid tobacco use, always engage in physical activity, and also, of course, I'm biased, visit cancer.org for more resources. We do have our NCIC available for you. It's our 1-800 number. We have 24/7, 365 days a year. People ready to talk with you, chat with you regarding any questions you may have. We also have our ACS Cares app, which is community access to resources, education, and support. It's basically an app filled with content, programs, and services to fit your specific needs if you or someone you love is diagnosed with cancer. Really simple app to use. It's amazing. You get access to information 24/7. You actually get virtual support as well from trained ACS volunteers. And another really popular program we have here at the American Cancer Society is the Reach to Recovery program, which has been available for over 40 years and helped over 1.5 million breast cancer patients. It's basically where we have trained volunteers who actually have or had breast cancer that meet with you one-on-one virtually for support. They're matched, so you're matched with a volunteer. That way you can learn from your from their background, and they can listen to your story and just really have this connection with someone. So this is a really popular program. Again, we also have our Road to Recovery program here at ACS. It's basically where we have volunteers, trained volunteers, take you to receive your cancer treatment back and forth to your health system. Again, these volunteers are trained, and it removes the barrier of transportation to receive treatment. Ways you can help is either share posts about this program, post it in your community, bullet boards, mosques, churches, anywhere you meet with people, talk about it, promote this program, and you can become a volunteer yourself, signing up online, and it's really easy, and you get a lot of benefits from it. And I know you mentioned before the interview that Grace Health had a form of transportation for patients.
Yep. Yeah. So Grace Health does have a large resource specialist team here, and we can help you with anything from dietary advice to different resources to even acquire some of the food and necessities of your life, all the way up to transportation to any of these visits. We make a lot of recommendations for screening intervals, and we're willing to work with you and help you get to those appointments and wherever you need to go. All it requires, honestly, is talking with us and telling us what you need. That's the best way to start. Grace Health is working with the ACS again on February 13th for our Cancer Prevention Month. And on the February 13th, you can come by, talk to providers here, get scheduled for different exams you might need, different preventative measures that could be pertinent to you, and we can help you along that road as well. So that's February 13th. It's going to be Grace Health and the ACS again here.
Yeah. Wanted to thank Grace Health for this wonderful opportunity to speak with you on cancer prevention. And again, if there's any other questions that come forth, please send them our way and we'll be more than happy to answer them. Thank you.
Thank you.